and manager of the Mayo Clinic Center for Innovation Design team, a dear friend and colleague, and one of the most talented people I know. Do you need this?
Getting my stopwatch queued up.
I think we got gypped on these seats. They had nicer ones for the other panels.
They have
Where's the Mayo planners?
These are like.
Good morning. I think the previous speakers have relieved me of the duty to introduce this topic, but I'll give it a shot anyway. I can get my glasses on. I have the pleasure of talking this morning to three innovation leaders. They all practice the methodology that you've been hearing about, variously known as either design thinking, human-centered design, service innovation. Matters less what you call it than what it achieves. The goal, as the previous speakers have noted, is to create dramatically improved healthcare experiences for patients, families, nurses, hospital staff, everyone. And in doing the work that they do, the designers focus not just on how the process operates, but on how it feels to be inside of it. It's a painstaking process of inquiry. It takes time, lots of observation, lots of experimentation, iteration, brainstorming, storytelling. But I think that the most important thing that I've observed about it is that it takes a lot of patience. I don't mean human patience, but it takes those too. It takes the patience not to rush ahead to find a solution before you've fully scoped and understood and investigated the nature of the problem. And getting to that depth of understanding requires enlisting all of the interested parties as your co-designers. I got interested in this subject, the intersection of design thinking and healthcare, while I worked at the Harvard Business Review. I edited an article by the now ubiquitous Tim Brown, the CEO of IDEO. In the course of doing that article with Tim, he pointed me towards Kaiser Permanente, and I know he's also worked with Mayo. So I wrote an article about Kaiser's experience with design thinking, and it runs in the current issue of the Harvard Business Review, so rush out and get it.
Please.
But in the course of doing the reporting, I came away really convinced and inspired by the idea that healthcare and design make a great combination with the potential to really transform the work of caregivers and the lives of patients, and that's certainly been made clear in the previous presentations. Interestingly, our panelists, even though they have converged on the same basic activity, got there along different paths, interestingly different backgrounds. Chris McCarthy, on the end, has a master's in public health, health policy. He also has a master's in business administration. Michael, his main focus is organization development. But he also spent 6 years as a clinical psychologist in a hospital in Pittsburgh. And Lorna is the only one of the panelists who has formal design training, but she's spent the bulk of her career working with professional geeks, scientists, engineers, healthcare professionals. So I think of all of them as experts, but I'll bet you that they'd rather be thought of as lifelong learners. Because that's really what they're engaged in doing. Chris told me that although they've come to think of themselves as pretty competent in design thinking after 6 years, there is huge room for improvement. So for the next half hour, the goal is to find out what they've been learning as service designers. And I'm going to talk to each of them individually. The goal is for us to give you a sense of what they do and how they do it. And I'm going to start with Lorna.
Okay.
So give us an example of something that design thinking can do at Mayo that some conventional method of innovation might not do as well.
I think design and design thinking, healthcare is so incredibly human, and I think that designers were kind of trained to really be fascinated by the human condition and to kind of examine it and have a kind of heightened sensitivity to witnessing, particularly the extremes of, and kind of everything we observe has a story, and we're, I think, trained to see and to observe and to document what we see. And so working in the area of healthcare, we have that heightened sensitivity, I think, to the user in terms of, and a level of empathy that makes it, we quickly kind of capture and synthesize what we see, and I think we kind of store it as being part of a kind of catalog that we have around the human condition in general, but then particularly in healthcare, there's so many moments where the experience of health and healthcare and illness is so personal, and it's not very generalizable, and I think that need to represent that experience at a really granular level is really important in decision making. I think it can't be generalized, and so maybe our role is to try and always bring the conversation back to the individual and then generalize from there.
Can you give me an example of a project that you've done that achieves that?
Well, that's hard. I think one, because I know that you wanted us to mention projects, and so one that I was thinking of that's slightly different than what I just described is we recently worked on an EMR Lite, which is like I guess a mini version of an electronic medical record, and it was for small practice, 10 physicians or less, and so not typically what the experience here at the clinic is. And two things happened. We were asked to kind of collaborate pretty quickly on that project and to bring a perspective. I mean, it was already, and it was an ongoing initiative that had started. And frequently we get brought into projects after they've left the gate. So and a lot has been defined and a lot has been determined and decided. And often we ask permission to go back and to ask questions about many of the assumptions that are already being.
So you could undecide something.
We undecide a lot of things, yeah. We're obnoxious at asking questions.
Excellent.
We get a really bad reputation for that. And it's hard because some of the questions that you ask don't appear to maybe be the ones that are universally considered relevant. So it's like maybe asking questions that don't connect. They connect for you, but they don't connect for other people. So what we were able to do in that project really quickly, it was a great team, was to think about it, reframing the product as a tool, and so really applying just the universal principles of design around what a tool should be in terms of how it needs to support and optimize the potential of the user, ideally be expressive in some way or creative in terms of how it could be used. And then the second thing we did was knowing how much we like to tap into the knowledge base in the community of Mayo, we were able to kind of go back in and know that so much was already understood about the experience of moving from paper to electronic. So we had this like wealth of there was a knowledge base in the clinic that wasn't being accessed. And so because we like asking questions and having conversations, we went back in and we were able to look at what was going to happen in small practices by trying to reproduce that experience or examine the experience the clinicians had here, moving from paper to electronic. And so I think as a group, we partnered with the existing project team to kind of offer very, very quick access to insights. We knew that they were already going to be available to us, so we just tried to kind of bring them to the table, and it was pretty rapid and I think pretty successful.
Great. You're a native of the design discipline and the only one on the panel, so I'm going to put you on the spot. How easy or difficult has it been for designers at Mayo to find a niche in a healthcare culture?
I think it's harder for us to find them than for them to find us. I mean, that's been my experience. And that could be, maybe the same thing. It's something that's not being, designers are not being educated to this competency yet. And so many of them arrive at the kind of intersection between design and healthcare themselves in a really circuitous route. And that's unfortunate because it is so circuitous, you can't really predict when someone's going to turn up with the skills that we need. And I do think it's probably something that needs to be looked at more by how designers are being educated. Also then, the kind of characteristics of designers that would function, particularly in a culture that is so profound, such as Mayo, they need to have a really interesting kind of mix of amazing amount of confidence, but being really humble as well.
Right.
Being very resilient to the environment they're in. And I think that there's a lot of, we see it on a kind of, Maggie calls it the X factor, and you see it at a really individual level rather than at a kind of general level. We kind of know it when we see it in designers, but it's hard for them, I think, to know how to become that designer themselves.
I do. The sense I get from all of you, though, is that design thinking entails a lot of humility, and that as you, I mean, and you have an entire career, really, of working with people who are extraordinarily talented and gifted in their fields and helping add your design expertise to what they do. So you, as a leader of this design team, have a lot to impart to the people who work in it. Do you find yourself coaching a lot in terms of?
I think I thought maybe at certain moments. I mean, I think it's kind of protecting your group and trying to kind of optimize what they need to be successful. I think what's curious about what I've discovered about the people that I work with is that there's something very personal about, there's something private about the designers that are attracted to working in this area. And it's almost like something's happened that has drawn them to this. And so they have much deeper reserves than I can kind of access. They seem to kind of bring it themselves. And so it's more about, I think, creating in the environment where they can be successful rather than really needing to coach them too much. They are highly motivated and I think kind of profoundly curious about their potential to impact. I mean, there's this kind of always this potential to, with every project, reach further and be more successful and feel more impactful. And that's really kind of addicting to designers, to be able to kind of feel the impact of what they do.
One of the things that when we talked earlier you mentioned as an ambition is the goal of helping Mayo create more empowered patients. And one of the things that occurred to me when you said that is that my experience as an occasional patient and my observation of people who are patients is that they come to the experience of healthcare pretty intimidated, often frightened, often feeling exactly the opposite of empowered. So I'm wondering how you might go about creating a greater sense of empowerment in patients through the design process.
This has been a kind of recent kind of, I guess, shift for me, and we talk a lot about the needs of the patient, and we kind of focus as a design group on really understanding and examining the expression of need and kind of scrutinizing it and kind of deconstructing it back and defining this is the need. And I think that we're really needing to, it never felt really satisfying. It felt like we were focusing on an expression of something very desperate and kind of negative, and it was like when you think about stories, it's not really it didn't feel complete. And so I'm thinking a lot more about focusing on potential, that there's more interesting conversations to be had with patients around their potential than around their need. And it's just, being able to shift the conversation we're currently having, I think, trying terribly hard to be really, really dedicated to this conversation, to kind of starting a conversation around potential and then maybe moving towards need, but not starting with need, because it would just be a more positive and empowering, I think, kind of way of framing their role in first identifying what makes them strong and what makes them, what they do well, and then talking about, because illness doesn't define a person. A person's not defined by their illness. And if you start a conversation exclusively around an expression of an illness, you don't understand the complete person. So examining need is a little bit dangerous, I think.
So you lead them toward their strengths.
Yeah, you should establish together as a team, what are your strengths as a person, and then let's talk about your illness, not let's talk about your illness. And then if we have time, we'll talk about you as a person. It's more important, and it's like context, but it's different to context. I think potential is really interesting. Optimizing the role of the patient first.
Yep. All right. Very quickly, in about 15 seconds. What project would you undertake in a heartbeat if you had the opportunity tomorrow?
I think as a group, we're really interested in, there's two things that we hear a lot about, sorry, 15 seconds, infection control in the hospital and falls. And not because that speaks to anything about what I've just said, but sometimes we really like to, we know there's so many kind of sentinel events, particularly around infection, and it just feels really tangible, and it's like something that we like every now and again to be kind of the stealth team. We'd love to be given a month to work on it and really come back with something that we hope we could make, because it impacts so many people.
Yeah.
And the outcomes can be so bad just based on that. And
I stumbled a little coming up the stairs.
we can help you.
Thank you, Lorna.
Thank you.
Michael,
Yes.
you come at design and experience design from the perspective of organization design, and yet you have this clinical psychology experience. Can you start by giving me an example of a project that you've done at UPMC that couldn't have been done in some other way than using design thinking?
Sure. Yeah, I'm one of the folks that Maggie was talking about that sort of came upon this almost by accident. I'm actually focused on patient and family-centered care. That's what the Innovation Center at UPMC is our role, is patient and family-centered care. We've actually put a methodology to this, and we're trying to kind of spread this methodology around. Well, everything, so much of what Jill and Jim were just talking about earlier, the steps in their process are so similar to what we do that it turns out that patient and family-centered care design thinking is intrinsic to patient-centered care. If you're going to really start looking at putting the patient at the center of the universe of care, that it needs to start with design. So there's every single project that we've undertaken really falls into that category that couldn't have been done as quickly or effectively without design involved. I think an example is the way we pull our groups together. The first thing we do, is shadow the current experience, so everyone knows what is our current state, what are we starting with. So we shadow that intensively with the patient, fly on the wall, watch everything the patient goes through. We do this with folks who are not at all part of that care experience because of the concept of, you can't see the forest from the trees. If you're embedded in it, you don't see so many things you just miss. So one of the things that occurred not too long ago in one of our groups, our trauma work group that we have, is that at the University of Pittsburgh Medical Center, there's a Presbyterian hospital with its trauma unit, what used to be right next door to Children's Hospital. And, occasionally when there would be accidents with traumas involving children and the parent, they would at least be next door to each other, and you could literally wheel the parent over to the Children's Hospital after they were worked on enough to go see what their child had gone through and what their situation was, and talk to the doctor in person. Well, just recently, our Children's Hospital had to be moved. We outgrew the space, and we just recently designed a state-of-the-art Children's Hospital, but it's a few miles away now, several miles away. So we don't have that ability to connect the parent with the child, and this was something that a lot of people normally you just don't think so much about. But in our work groups, it came to the attention of some of our caregivers, and they started thinking immediately of, because we teach them to think of the ideal story, as again, just Jim and Jill talked about. What's the ideal? Not how do we make this better, but what would be ideal in the land of Oz if there were no barriers? And so people started thinking about, well, we could somehow magically transport them there. Well, we can't do that, but the next best thing is we could come up with a webcam and connect them through the computer, where at least they can still see their child, see what their injuries look like, rather than just hear about it, get a chance to actually communicate in real time visually with their child and the doctor, and still learn as much as possible about it. This was a tremendous success, and really very well received by patients. They can't speak highly enough about that, and that's just one project of literally hundreds.
That's great. Now, In spreading this gospel of patient and family-centered care, putting patients at the center of the universe, does that create any conflict with other stakeholders in the process? Maybe physicians sometimes?
Yeah, that's not a loaded question at all.
No.
Actually, it is interesting how many of when we shadow the current experiences, how many times a patient will come in for an office visit or a follow-up visit, and we're shadowing them, and we learn that, well, they were waiting for 2.5 hours to see the doctor. They were, then after seeing this doctor, they had to go down for another procedure, which was not only down the hall, but in some cases, our medical center looks a lot like this campus in that there's bridges and skyways, and sometimes they'd have to travel 1/4 mile through skyways and tunnels to get to another procedure. And we would ask the question, why? And oftentimes, unfortunately, the answer was, well, that's more convenient for the doctor. The doctor will triple book a patient because it's more convenient for them to have them there at that time. And the test that they need is over here. Well, why can't we move the test closer? So yeah, there are some folks that do resist a little bit more, and it will change. The way that we approach patient and family-centered care will change the way that they operate and they work. So we do run up against that. We do run up against that sometimes. The way we approach it is we don't try to say our way is better or butt heads. We just ask them to check us out, check out what we're doing. Sit in on our work groups, learn a little bit about it. If you can just spare an hour here or there for one of our work group meetings, listen to what we're trying to do. We have actually bridged some gaps with some physicians. We now have some surgeons and physicians that belong to our working groups, and it's just a slow process. They're starting to come around and see the benefit long term. We also have some tremendous champions. The founder of the patient family-centered care methodology that we use is actually a surgeon and an engineer as well. And with him as a champion, I have to say, we probably we may not have even gotten off the ground without his support and influence, but it certainly has made a difference.
So maybe you could talk a little bit about the work groups and the way those are kind of the leading edge of your vanguard to spread this patient and family-centered care philosophy throughout the entire institution.
Yeah, we don't get me wrong, we do want to let people know what we're doing. We do want to spread the word. We don't do a lot of selling ourselves. We found that we really don't have to. We just ask folks, if you have a care experience that you want to really look into improving and transforming, take a look at some of our other work groups. Just visit one of our other work group meetings. Sit in on one. It's 1 hour of your time. What ends up happening is we're spreading grassroots. We're spreading organically through this process where people are just saying, oh yeah, you've got to talk to those folks at the Innovation Center. They have done tremendous things with our group.
It sounds sort of cult-like.
Yes, yeah, yeah. It's been tremendous. I will say I joined the Innovation Center in 2008. I've been there just 2 years now. When I started, we had 7 working groups. We now have like 32. And in the last year alone, we've brought 20 new folks, 20 new groups on board. So really, it's starting to become exponential now. And I think it's just because, quite honestly, it's just shown to work.
You have 32 working groups, but there are only like 11, is that right? 11 people on your staff?
Oh, my staff, yes. Yeah. This is something that we do not, the Innovation Center does not do patient family-centered care. We just facilitate the process. We just teach the process and then let the teams run. They are self-directed, they run themselves.
Okay.
Yeah.
So, if you had to pick a project that you had unlimited budget for and you could begin it tomorrow, what would it be?
Okay, this is stepping outside of just healthcare, I'm going to look at the bigger picture a little bit. I would like to turn design thinking and even the methodology that we use toward the very structure of not just hospitals, but organizations in general. I really think that there's a better way to organize. In fact, I know there's a better way to organize people around work. I think that the pyramid needs to crumble. I think that hierarchy and bureaucratic, it just gets in the way. I think that We've shown a better way, and I think that we really need to turn that focus toward literally just designing better organizations and how people connect in those organizations.
Maybe when you're done with that, you could take on the financial system?
Small undertaking, yes.
Yeah.
Thank you.
Thank you. Chris.
Yes, Lou.
Chris.
We're old hats at this now.
So describe for me a project that you've done at Kaiser that you wouldn't have been able to do as well or as quickly or as happily in some other way.
Yeah. Well, like these two, I think one of the really unique aspects of design thinking is really starting with the observation and understanding. And going back 7 years ago to one of our first projects on redesigning the shift change for nurses. Traditionally, we probably would have just talked to nurses and tried to figure out with them how to make a better shift change. But because design thinking is multidisciplinary, because it uses left and right brain, we were able to get somewhere different. So very specifically, my favorite technique is draw your experience. So we have our nurses, our doctors, our patients, our administrators draw the experience of nurse shift change. Now nurses wonder, why are you asking doctors or patients for a picture of what they think it should look like? Well, the answer is because the pictures we got back from our patients, they often drew ghost towns. They often drew their faces looking very distressed. One very perceptive patient drew a bunch of clocks, all very Dolly acid style, dripping, and every clock pointed to 7, and it just so happened that the shift change was at 7 in the morning, at 7 at night. And so by tapping into multidisciplinary teams, by tapping into new techniques, the nurses clearly got the message that the shift change is not about patients, but that it should be with patients. And so we went from taking a shift change that happened in back room, not just making it a bedside shift change, but making it a bedside shift change with the patient and family. And that would have never, ever have happened had we not used these techniques to get there.
Yeah, that's a great story. So there's not many of you working in the design group.
No, sadly.
The innovation consultancy. How do you decide which projects you want to take on? I mean, are there some things that are better suited than others? Do some things cry out, and do other things kind of warn you away?
Yeah.
How does it work?
We get the question we most often get is, how do we vet projects? How do we find them? And we don't have an official process, but there are some key success factors that we look for. One is we are constantly scanning the external environment for what are the big challenging healthcare issues that many organizations are facing. Our design team, although we design for Kaiser Permanente, we try to pick projects that other healthcare systems might benefit from our innovations. The second thing we look for is passion of leadership. Innovation and design work is very, very difficult to do, and you need good cover. And having really passionate leaders who can provide the protection and the resources to do the kind of work is really, really important. We also look for the problem to be universal within Kaiser Permanente. So we don't want to design for a single caregiver or a single hospital. So we look for multi-hospitals. And for me, the most important piece, although leaders might say not so much, is personal passion. Now, it doesn't have to be my personal passion, but somebody on our team really needs to have the passion to carry the projects, because our projects tend to go on for a while. Right. We go end to end, all the way from nothing to production of evidence that these prototypes are providing value to our system, and we call that an innovation. Yep. Or that they are not providing value, we call those failures. And so we're in charge from end to end through the whole piece.
Right. So taking it to the next phase, once you've settled on a project that you'd like to do, how do you pick the people to do to be your collaborators?
Yeah. So first, we definitely we look for those hospitals that are having the challenge within their system, but we're also looking for the type of hospital or clinic or setting that we're looking for is one that also is receptive to change, and so we do a lot of exploratory work with them at first.
Yep.
We are not looking for the discipline problems. We're not looking to change their views on themselves and how they relate to the world. I think a lot of folks want to think that design thinking can be great for that.
Right. That's a management problem.
That's a management problem, and it might be a nice side effect of our work. But the focus of our work is really to do things differently. So we're really looking for organizations that are ready for change, that have the problem. And then very specifically, the kind of people that we're looking for during the design phase are the B's and the A- kind of folks. The A+ and the A's, we love them, they're superstars, but they may not represent the totality of the population.
Right.
And the C's and D's, they're great too, but they may not have the energy to participate. So what we really find is that the average B kind of employee turns out to be one of the most energetic and most well-received in their peer groups. So when they participate and try changes and design with us, the rest of their peers tend to want to come along the design process later on.
Yeah. Now, it's one thing to work with your fellow Kaiser employees, but how do you pick patients? How do you find the right patient for the right project?
Yeah, we're terrible at it. So
there you have it, a best practice.
Yeah. So we always do have patients on our projects, absolutely. And we're constantly prototyping new ways of getting better at this.
Yeah.
Traditionally, just because of the way the healthcare system is and the way our society is, we get people who are retired, and we get people who are out of work, or we get healthy folks. And so trying to find ways that patients who you are designing for can participate can be particularly difficult, especially if you're talking about very ill populations. Like, how do you bring ill patients into a 2-day intensive design session?
Right.
So we're getting better and better. Every year we learn more and more, and we bring more and more patients into it, but I would not say that we have found the golden nugget of how to do this in the best way, but we're trying.
But there are levels of participation that even the very ill patients could be involved in.
Yeah, absolutely. And what we find is that the observation phase of this work is the easiest part for patients to participate in. For our most ill patients, we can come into their home and hang out with them for a day or two and experience their lives and take back their learnings. And so they're part of the design session in the terms of their stories, even though they may not be able to physically be present with us during those sessions.
Okay.
Yeah.
And finally, for you, if you had limitless funds, all of the people you wanted to have, what would you want to do tomorrow?
Yeah, my dream project would definitely be in the health and wellness area. It is absolutely ripe for design. But I think more importantly, what I would love to do is to link up some of our large healthcare organizations to do the design work together. That is, I think, just a major challenge. We talk about collaboration.
Right.
I think organizations are great at collaborating on learning and exploring and understanding, but organizations are terrible at designing together. And that's something I would love to tackle in the next year or two.
Well, you should talk just briefly, I think we have a minute or so left, about the Innovation Learning Network as a best practice sharing forum.
Yeah. So the Innovation Learning Network is a group of 16 healthcare organizations and design firms, all not-for-profit and non-competing, which is extremely important for this group. I wish that everybody could put their competitions aside and just get along, but by being non-competing and not-for-profit, we all are mission-driven. We're not worried about our competitive advantages. And the purpose is to link design groups and design thinking folks within these healthcare organizations to raise the level of technique and in learning within our organizations, and then to find common areas of collaborating on to work together. And we've been in existence for 5 years, and I can honestly say in 5 years, we have never collaborated on an actual design project. But it is, I think, is a grand experiment. We are fantastic at collaborating on understanding and building a lot of will to do design work within our organizations. And I'm hoping the ILN actually will get to the point where we will co-design in the next year or two.
Cool.
But we're getting there.
All right.
Yeah.
Well, thank you, Chris and Michael and Lorna. I hope we have stimulated your questions. Chris mentioned that since there are 3 of you, there should be podiums in the back, and we can give medals to all 3. So thanks very much.
Thank you.